Hi, everyone. Welcome to the Jobskin webinar series for 2024. My name is Adam Ho. I'm the Managing Director of Jobskin. With us today is Rosemary Kendall, our clinical advisor based in Australia, as well as Veronica Eichmann, our clinical advisor based in New Zealand. So today's webinar will be on vascular anomalies and garmenting for them. Originally, this was going to be presented by Rosemary, but she wasn't feeling quite well earlier in the week, so she did a recording of it. So we'll be playing the recording, and then afterwards, Rosemary and Veronica can help you take any questions. So with that, I will share my screen and the video. Please let me know if the audio is coming through. It should be fine, and we'll go from there.
Hi there, and thanks for joining us in our next webinar for the 2024 series. And today we're going to be looking at garmenting for vascular anomalies. You might wonder why this particular webinar, but this is an abbreviated version of the workshop that we recently presented at the Australian Lymphedema Association conference. And we chose to offer that workshop and now this webinar because Veronica and I find that these we get a number of queries about the challenges that vascular anomalies present. They're rare, and we don't really ever get the chance to become highly proficient with dealing with some of these anomalies because they're rare, and so therapists often feel isolated. We obviously provide practical support, but we were keen to seek out what evidence was available, and that was really the basis for this the workshop at the ALA and this webinar today. So let's start with a definition. Vascular anomalies are abnormalities or disorders of the vascular system, predominantly either veins or arteries, and they are classified as either a vascular tumour or a vascular malformation. So what's the difference between these two? There is a fundamental conceptual division between hemangiomas, they're tumours, and vascular malformations. The former, as I say, they're tumours, proliferating tumours, and the latter are developmental errors. They might have nothing in common pathologically, but they may have a somewhat similar appearance. Vascular anomalies manifest with a very wide clinical spectrum of lesions, ranging from small skin discolorations to very large life-threatening conditions. I'm going to briefly run through the 2014 classification as it's helpful for understanding the fundamentals, but then we're going to move on to what is now the current classification, which has some more subsets. So they are divided, as I've mentioned, into tumours and malformations. In the vascular tumours column, we have infantile hemangiomas. These are the most common soft tissue tumours of infancy, and they occur in about 10% of people. They're typically present during the first few weeks to months of life. They grow rapidly, then the growth slows, and they just spontaneously involute or disappear. Similarly, there are congenital hemangiomas, and they are either rapidly involuting, congenital hemangiomas, they're sort of called rich, rapidly involuting. Involuting means disappearing in effect or resolving. Or there are non-involuting congenital hemangiomas, niche. The latter grow proportionately with the child, and they're treated with surgical excision. Sorry, I forgot to advance the slide. Now, then there are three other kinds: tufted angiomas, KHEs, and pyogenic granulomas. These are rare. There isn't any routinely effective treatment other than that little image there is a pyogenic granuloma. They can be surgically shaved. But in the case of KHE, they can be potentially life-threatening. And actually at the ALA, we had a lovely case study of a little toddler with a KHE and with a therapist doing an absolutely wonderful job providing compression garment for that child. Now, let's look at the vascular malformations. They are, apologies, I've had this frog in my throat for weeks. These are vascular anomalies that occur as developmental errors. So they're present at birth, but they often worsen over time. They're classified by the type of vessels involved, but they are frequently made up of more than one vessel type. The first three that you see listed there, capillary, venous, and lymphatic, are classed as slow flow, whereas the fourth, fast flow, and we'll talk a little bit more about that later. So when we consider capillary malformations, there's two types. There's the nevus simplex, and these are very common in bubbies, and they typically fade by age 2. And I'm sure you've all seen a little baby who has like this pinky reddish marking on their face, and it just gradually resolves. The second type of capillary malformation is a port wine stain. These are dilated capillaries in the epidermis. However, sometimes they are associated with underlying lymphatic malformations or venous malformations, and they can be associated with other congenital abnormalities. If they are simple, they're commonly treated with laser. Then venous malformations. These are complex, tortuous venous channels within the skin, but they often extend into surrounding mucosa, soft tissue, muscle and bone. They can be isolated or they can be part of a syndrome. And they become more evident when the involved area is put into a dependent position. You hear them described as a bag of worms because that's kind of what they look like. And there's multiple modalities for treatment that include excision, embolization, laser, and sclerotherapy, but that's dependent on the size and the location, and they have varying degrees of success. Majority of patients with venous malformations undergo multiple procedures with multiple modalities over the course of their life. And elastic or compression garments can be used to reduce swelling and pain and to help with function. Lymphatic malformations result from a congenital abnormality of the lymphatic network, and they can be microcystic or macrocystic, as this image here, or they can be a combination. They can be superficial or deep. They're treated with surgical excision if they're well localized, and there's actually quite a wide range of medical management options. Compression garments might limit complications and assist with the control or the prevention of infections. Then this last category is the arteriovenous malformations. These are rare, fast flow vascular malformations, and they consist of a direct connection between the arteries and the veins without intervening capillary bed. They are potentially life-threatening, secondary to massive bleeding and high output cardiac failure. They are frequently associated with syndromes. They're most commonly head and neck, and they are very difficult to treat. Now, that was the classification system that was used up to 2018, and then in 2018, the International Society for the Study of Vascular Anomalies modified the classification system in an attempt to reflect the complexity of the range of presentations. You can see it's similar, but more comprehensive. This new classification attempts to recognise the complexity in terms of the fact that it reflects combined malformations like capillary venous, lymphatic venous, capillary lymphatic venous, and it also includes the syndromes that are commonly associated with vascular malformations, of which there are in fact 5, which you may or you may not come across. Sorry, I just had to have a drink of water because my throat's so croaky. These 5 syndromes, there's Kasabach-Emeret syndrome, which is a rapidly growing vascular tumour. Klippel-Trenaunay syndrome, I have to say this is the one that I have seen most commonly, and we see these, but the incidence is higher in the disability sector. They are a soft tissue hypertrophy and bony overgrowth of the extremity. That overgrowth is not present at birth, but develops, and so there can be significant limb length discrepancy later with prominent hypertrophy of feet and toes. Parts-Weber syndrome is similar to Klippel-Trenaunay, except that there's an AV malformation. Remember that rare fast flow condition, which occurs in association with a cutaneous capillary malformation and skeletal or soft tissue hypertrophy, very complex. Sturge-Weber syndrome is a very specific syndrome where a facial port wine stain occurs in the region of the trigeminal nerve, so that attracts its own little complex set of symptoms. And then Cowden syndrome, which is a rare inherited disorder marked by the presence of many benign growths, which carry an increased risk of cancer. So fortunately, these are relatively rare. However, for us, as I mentioned earlier, it means that their presentation can be challenging. That when most of these malformations present, they are seen as soft compressible blue masses that can enlarge with physical activity or positional dependency. They generally grow proportionately with the child, and they can undergo a sudden increase in size with trauma, sepsis, or most notably hormonal change. So obviously adolescence then becomes a time where there can be significant changes, and similarly pregnancy. Now the symptoms, there's 5 listed here, but you'll see there is a lot of commonality here. So there can be pain and swelling as a result of venous stasis. There can be pain as a result of local compression. So the malformation is compressing on nerves, muscles, or joint structures. There can be a reduction in joint range of motion as a result of the vascular malformation infiltrating tissues, or actually the mass effect of the presence of the malformation itself. There can be significant pain and swelling from local hemorrhage, and thrombosis and thrombophlebitis, DVTs, as a result of local stasis on the background of chronic localized intravascular coagulopathy also occurs. Essentially, what we're looking at is symptoms of pain and swelling with varying impacts. We need to be mindful too that the anatomic location plays a large role in the clinical presentation, and pain is the most common symptom, and it correlates with age, size, lesion location, and notably older patients with larger lesions in the limb and trunk report a high incidence of pain. So how does this all impact us? How does it intersect with us? The treatment that is suggested in literature includes local control with compression garments. This is where it intersects with us, obviously, but then also pain control, surgical procedures and debulking, laser therapy, sclerotherapy, and medical management. There is a very strong emphasis in the literature on a multidisciplinary approach, but actually I would qualify that by saying there's a very strong emphasis on literature. Although they say multidisciplinary, interdisciplinary a great deal, what they're really talking about is interspecialty or multi-specialty. So, you know, oncology, dermatology, vascular, pediatrics, you know, there's a very long list there. And allied health gets a fairly scant mention. So when we consider that really where we intersect with this clinical presentation is compression, let's look at the evidence for the use of compression. There is scant guidance in literature, I have to be honest. And I'm sure some of you will have a wry smile at some of the information here, because some of it is really, it's compression 101. It's what we learned as students or as young therapists, and a lot of it is, in my opinion, is stating the obvious. So one of the articles talks about the fact that these malformations are troublesome, and compression garments might assist with symptom control and post-op management. Another article talks about the fact that the symptoms can improve by reducing phleboliths, which are like little calcium nodules or granules in the vessels, by reducing DVTs, by reducing pain, by reducing swelling, and provides the guidance that compression is best worn during the day, while awake, and during exercise. That same article goes on to say that garments should be measured for by an experienced occupational therapist or physiotherapist, and also we would include nursing staff in that. Compression can be started at 15 to 20 millimeters of mercury and can increase gradually, titrating to patients' symptoms, which is something that I think most of us would say we do in our clinical practice. They should be customised for the shape of the malformation, and they should account for activities and preferences to make them more agreeable to wearing the garment. This is kind of the wry smile page here, I think. Children should be empowered to choose the particulars of the garment to improve patient compliance. They should be replaced every 6 months and 2 provided, 1 to wear, 1 to wash. Babies and toddlers might need their garments measured more frequently to account for growth. The garments are best introduced early and continuously. They improve symptoms by slowing the progression of venous distension, by slowing the progression of deformity, by slowing the development of ulceration, by reducing pain, by reducing chronic localized intravascular coagulation. So thereby, and this is a really helpful reminder, as it reduces the need for other therapies. In adults, pressures greater than 18 millimeters of mercury are defined as therapeutic for vascular malformations, but unfortunately there are no evidence-based guidelines for children. So there was one article in particular that I thought was the most relevant for us, actually. It was a systematic review that considered, from memory, about 165 articles, but in the end they only included 5 that met their criteria, and even so they were circumspect in their assessment of the quality of the research or the studies. So in essence, the gist of this article was that compression is seen as first-line therapy, but there is no high-quality evidence, and none of the articles quantified the benefits or harms for wearing compression. It mentioned specifically that more information is required, particularly about 2 essential elements: the amount of compression exerted and the elastic features or stiffness of the fabric that's used. It noted that excessive pressure may harm skin, hinder arterial flow and affect mobility, whereas too little pressure may be insufficient and so not control swelling and edema, something we would definitely not take issue with, and notes that pressure needs to be sufficient and constant over time. This article very clearly was critical in the fact that said no studies mentioned brands. There was no consideration or recording of brands, of materials, and that includes the construction of the garment, or measuring systems, and there was nothing about wear regimes. Goes on to say, look, why is there no evidence? And speculates that really it's because there's just an assumption that compression is beneficial. But obviously that lack of evidence is problematic. So let's just quick revision about what we know about compression. And that is that Pressures between 6 and 50 millimetres of mercury are routinely used to treat a variety of medical conditions. Subdermal pressures range from 9 to 90 millimetres of mercury, depending on the location. That's not rocket science. We know that the amount of compression that would be applied over a bony prominence like a ulnar styloid compared to the amount of compression that's over a large belly would be drastically different. We know that skin and fat have different properties. Skin is squeezed less when it's over underlying fatty tissue, and obviously even more so when there is a considerable amount of fatty tissue. We know that more measurements lead to a better fit, but we also recognise that changing curvature results in different millimetres of mercury. So let's just keep that in the back of our mind when we then go on to consider vascular anomalies. So it really is essential, if you have somebody who presents to you with a vascular anomaly or a vascular malformation that needs compression, that you or we take a problem-solving approach. The patient's symptoms are the critical base for prescription. If I compare with, say, somebody who has a burn injury and they've had skin grafts, we know that we need to apply 25 to 30 millimetres of compression. We know that if we take body measurement circumferences, that we trust the manufacturer. I know that Jobskin has got a extremely reliable way of calculating garment size and tension to ensure that therapeutic compression is applied. We know that we're going to get the result that we want. We know that the garment's applying the right compression, it's achieving what's required or requested for scar management. But vascular conditions are different. Actually, we're not just applying a formula, or we're not following something that's evidence-based to the same degree. So the patient's symptoms are essential. Now, the changing volumes present a unique challenge. We had one of the studies we used at the ALA, which unfortunately, because this webinar just goes up into cyberspace, we're not prepared to use patient images quite so readily as we can when we're doing a face-to-face presentation. But one of the case studies that we used at the ALA was for a person who had a large vascular anomaly that went from fingertips to including part of the chest, similar to what you see here in terms of the chest. And the changing volumes were extraordinary. So when the hand is above the head, it's a near normal limb volume. When the hand is in a dependent position, the limb is totally engorged and enlarged. So how do we measure? Now, in that particular instance, the therapist had a really helpful insight, was that the Jobskin paper tapes offer a really unique solution. When you consider this image, this is Veronica's arm, thanks Veronica, wrapped in paper tape. And you can, those of you who've used Jobskin paper tapes know that we wrap the paper tape circumferentially around the limb, and then we secure it on a little adhesive spot at the top. And our general procedure in the case of an upper limb is that you hold the hand out, rest it, say, on a table with the palm down, and then we wrap the tapes around. Now, what position do we use when somebody has vastly changing limb volumes? Should we measure above the head? Although that can be problematic, because then as the limb moves into a dependency position, the pressure exerted by the garment is just too excessive and then becomes a source of pain in itself. But if we were to measure in the dependent position, it's not really achieving anything, because it's just reflecting the measurements when that limb is in its, for want of a better word, its worst state. So the therapist in the case of that particular patient offered this helpful insight in that by using the paper tapes, the limb could be secured in a neutral position like this. The tapes could be secured rather, and then the limb could be moved into varying positions and the tapes tweaked or adjusted based on the patient feedback of pain and comfort. So that's a very helpful mechanism. And what I would say about vascular anomalies is that this is a great opportunity for collaboration between therapist, clinical advisor and designer, because they are complex. We don't expect you to do this by yourself, and clinical advisor and therapist work together to really consider broadly how a garment can work in that for your particular patient. But the insights of the designer is really helpful as to how that garment can be constructed to best meet the patient's needs. So we're delighted to work in those sorts of circumstances, and I would reassure you that when garments, if they're not perfect the first time round, Jobskin offers a first fit guarantee so that we can tweak and make some changes, which is very reassuring when we know that or particularly either it's patient self-funding or when we're using public monies to provide garments, we need to have some kind of reassurance that we're not going to be wasting money. So that's kind of a nice little safety net for you. So I mentioned the role of clinical advisors. Veronica and I are here to assist you when you have these complex cases, and the design team, they're always up for a challenge. There's contact details there for you. And I would just remind you that on jobskin.com, we have over time, we've been assembling a vast range of resources under the support and training tab. There's measuring videos for different body parts. All the resources are there. We have links to previous webinars, to lit reviews, work that we have done over time with different conferences. So we would invite you to take advantage of those. When you order a garment, most of you would know this, you need the order form plus the relevant measuring form. And in the case of something like a vascular anomaly, taking photos with the photos, with the tapes in situ is really helpful for the design team. We can be contacted at customer service at jobskin.com, and if they can't help you, they will pass you on to one of us who can, and the phone number is there on the screen. And again, I have missed the New Zealand number, so Veronica would be very happy to provide that for you. Now, we can take some questions, but I just want to remind you that our next webinar is on the 25th of July, and it's on the fabric selection in garments. So how we use different types of fabric in garment construction and how that impacts your prescription. So we'll take some questions, but thank you for your time today.
Cool. Thank you very much for listening to our webinar. It's good to hear that Rose is feeling better. If you have any questions, please feel free to unmute yourself or type them in the chat, and I can read it out to the clinical advisors. And yeah, we can go from there. I'll give you guys a couple of minutes just to see if you have anything. Right. Seems not. Well, then, thank you very much for joining us today. As always, we're here to help and assist. So if you have any other questions after the webinar, please feel free to reach out to Rosemary, Veronica, and myself. And other than that, enjoy the rest of your day, and thank you very much for joining us. For those who want CPD certificates, just make sure you've registered on our website, and then we'll send it out after about a week or so. Cool. Thank you all very much, and we will see you We'll see you guys next time. Cheers.